Hello, Dan. Can you hear me?
Yes, I can. How are you, Eric?
I'm good. We're going to make you the presenter right now.
All righty.
And we've got Arjun, Calvert, Jody, Josh, Maria, Nadine, Patricia, Sebastian, Serena, Susan, and Verneda.
Okay, sounds like a great group.
We got a great group.
You can see me? This is Xia. Hi, Dr. Dan.
Hey, how are you?
Good, thank you.
So this is kind of a
Hi, Dr.
complex. Hello. Yeah, this is kind of a complex case. So I thought I'd share it with everybody and see if they had any insights as to how we best proceed. So are we okay to go ahead and start, Eric?
Go ahead and start, Dan.
All right, perfect. All right. So this is a really interesting and challenging patient that we've recently been dealing with. A 57-year-old female had ALL in 2000, so when she was about 40, and was treated extensively at the time, but ultimately got into a complete remission, and then several years later developed a very prolonged ICU illness with ARDS in 2009. Wasn't really clear what the cause of it was, other than presumably some infection, but I don't know if it was ever identified. Who now is admitted to the heart failure team with severe shortness of breath that had worsened quite significantly over the past 3 or 4 weeks. She denied any chest pain, did have some palpitations, and had noted that her blood pressure at home had been 80/50 on many occasions in the past few weeks. Her notable past history was that she was initially diagnosed with ALL in 2000 and got a variety of chemotherapy for over about a 2-year period. That included adriamycin, Ara-C, methotrexate, VP16, and also intrathecal therapy for her leukemia. They had considered whether to do an allogenic stem cell transplant at the point of her achieving remission, but because she had developed cardiomyopathy at the time with an EF in the 40% range, they did not proceed with a allogeneic transplant at the time.
When was that, Dan?
That was like in 2002. So she was originally treated in 2000, and then over the span of a year, she developed, a mild reduction in her EF by MUGA, and at the point that they were considering whether to do the stem cell because her EF was mildly reduced, they opted not to. So things happened over the next decade, including the episode of ARDS, which I mentioned. In 2009, also, she had a partial AV nodal ablation for AV nodal reentry tachycardia, which they ablated her slow pathway. And then her EF, as recently as in 2014, was felt to be about 35%. During her episode of ARDS, which was a prolonged ICU stay, she ended up having a tracheostomy at that point, but currently that was closed up. And as a result of her ICU stay, she had, as she said, she had not only chemo brain, partly from her intrathecal therapy, but also developed PTSD because of all the horrors that occur in the ICU. and then she had intermittent atrial fibrillation, over the past several years.
What's the cumulative dose of dramamine, please?
I think it was around 200 milligrams per meter squared. She got induction therapy for her ALL, and then after they gave her induction therapy, they switched to the Ara-C and methotrexate. So I think that the total combined dose was about 200 milligrams per meter squared. Her physical exam, current day, blood pressure was 98/51, heart rate was about 104, respirations 26, afebrile, O2 sats were okay. She had significant JVD, some crackles in her bases. She did have a loud S3 and her PMI was enlarged. She did have a relatively soft holosystolic murmur and the apex, and then she had trace edema and palpable pulses. Her labs were highlighted there. Of note, her BNP was significantly elevated at 1800. Troponin was negative. She had a BNP done in 2015 when I saw her when she was otherwise stable, and her BNP at that time was about 200. So this was significantly different. This is her EKG from 2015 when I saw her, and she was relatively stable at the time. Anybody want to comment on what they see there?
Got almost a left axis, maybe minus 25 or so. Wide QRS complex with a terminal conduction delay, poor R-wave progression, normal sinus rhythm, probably left atrial enlargement, ST and T wave changes, sort of non-specific, might be ischemic, and so IVCD is pretty prominent of indeterminate type of IVCD. Septal forces are abnormal.
I would also add that the QT interval does seem prolonged.
Yeah, it's quite prolonged. And that was when she was basically stable. She was still probably had class 3 symptoms, but was able to walk, a couple of city blocks. No PND at the time. EF was about 30, 35, roughly. She actually, at the time, she had that AV slow pathway AV nodal ablation procedure several years ago. For a while, she didn't require a pacemaker, but then shortly after that procedure, she did require a dual chamber ICD because her EF was in the 30s and she was still having issues with bradycardia. This was, I think it was implanted around 2012. And then when I saw her in 2015, this is the device interrogation. So does anybody want to comment on what this information? I will add that the current day device interrogations are about 30 pages long, and they have 10,000 different pieces of information. But I would just be this is just one page that I pulled off, and so I don't know if anybody wants to comment what they see here.
Which kind of drugs she was using at that time when you saw her?
Yeah, in 2015, her medications were, I'll skip all the minor stuff, but she was on 20 of Lasix, spironolactone 25, Eliquis 5 milligrams twice a day, Ticocin 500 micrograms every 12 hours, and metoprolol tartrate 25 milligrams twice a day.
I'll be happy to comment on the ICD interrogation. So you have two columns to the right. One is the data compared to the last reset, which is the 24th of June, and then the device totals is the column to the far right. So what it denotes is that in the period since the last reset, she's had 172 episodes of non-sustained ventricular activity. She had not had any antitachycardia pacing, and she had not had any shocks. In the total for the entire device, she only had one actual shock delivered, so that would have been in the period prior to 2014 to the time of implant. And then in the lower section, it indicates what is the percentage of time she paces in both the atrium and the ventricle. She paces 20% in the A and 9% of the time in the ventricle. And she's had less than 1% estimated atrial burden, and that usually is a cumulative of atrial fibrillation, atrial tachycardia, or supraventricular tachycardia.
Super. Yeah.
So, Dan, I'm really concerned about the QTC interval on Tickerson 250 BID.
Yeah. Yeah, well, it is prolonged, and she also has non-sustained VT, which was just, highlighted. She has had, one therapy delivered in the past. I don't know if that was at the time of implant or not. As far as I know, she did not report any ICD shock in 2015. And then, as was pointed out, there's really not that, there's hardly any atrial fibrillation that was recorded through the device.
So was there some consideration to upgrading her device to a CRT-D, given her intraventricular conduction delay with a left bundle type pattern at the time of implant or subsequent?
Yeah, excellent point. I couldn't have, that's like a softball, man. You just pulled that one right out of there. But yeah, no, so when I saw her in 2015, and with this interrogation, with the prolonged QRS and QT prolongation and an EF of 35 or so, Tickerson didn't seem like a great drug for her. And then the other item was her short-acting metoprolol was really not optimal. I did not feel that that was the appropriate therapy for her significant heart failure. Because number one, that's not the best treatment for just systolic dysfunction in general, but also, there are some comparative studies showing that Coreg, for example, is better at suppressing VT and ICD shocks in people with significant LV dysfunction than metoprolol short-acting. So,
Dan,
anyway.
do you think her QRS is long enough to support BIV pacing in terms of benefit?
Yeah, it's kind of right on the border, but I would have, actually I did recommend it to her very strongly. Because, as it stands right now, she has an atrial lead and a ICD RV pacing system. That's her current device. And she was pacing in the ventricle 10 to 15% of the time. And in people with systolic heart failure, that's not an optimal treatment. You don't want to be pacing in the right ventricle. And then with the QRS being sort of borderline prolonged, I had recommended very strongly that she get an upgrade. But because of her PTSD and her long ICU stay, she was like not into that idea. And also, I think she was kind of offended when I told her that I thought metoprolol or Ticocin were not optimal choices. And so she actually didn't come back to see me for over a year because I was offending her. So this is her echo. Is it? It's. Oh man, I thought it was going to run here. Yeah, I think that. Let me copy that 1 second.
Yeah, remember that thing where we'd copy it and then it would run, but it wouldn't run first?
Yeah, let me do that here real quick. Come on now. My computer's not happy today. Oh boy. Come on. Try it one more time. Oh man. Let me see if I can get them to run.
So Dan, it looks like the LV is dilated, and you can see right ventricular pacer lead. Looks like some little TR, some MR there. Wall motion appears to be static at this time.
Okay. I will go to the source here. I don't know why my loops weren't working, but let's go with
Let's see, Marty, we sent you a link. If you want to come on with your audio pin, we sent you a link.
okay, so this, yeah, this is the play.
Dan, we have wall motion. We can see it. We have wall motion.
No, but this loop is okay. So there's the sorry about the technical limitation there. This is in 2015. This is her short axis LV or echo. So I don't know if anybody wants to comment on what they see there. This is like I said, this is 2015.
Sebastian, would you like to comment on the echo?
Global hypokinesia.
And what would you visually estimate the EF based on this one view?
Probably on the one view, probably around 25 to 30%.
Okay. Here is, let me get this. There is, let me see, come on now. Having some technical problems.
Did you have any strain volume values? I'm sorry.
No, don't have, didn't have strain back then. This is in 2015. So there's her 4-chamber view with some little bit of MR. I don't know if anybody what they feel about the severity of the MR there.
Hi Dan, I have the question about the function of right ventricular.
At the time, it was felt to be normal.
Okay.
Sort of see, you can see a little bit over there of the RV lateral wall. and that looks, or looks okay. So then let's go back to the So in 2015, as was already pointed out, some of our options include continue her medications as it stands, which I didn't really feel like the Ticacin or the metoprolol short-acting were optimal choices, but anyway, that she didn't want to change her medicines. She would agree to doing cardiac rehab, which is why I signed her up to do that, which actually was good. She did complete it and had some improved functional status after doing that. And then, as we discussed earlier, the question is whether to do a device upgrade. And she wasn't really amenable to that idea. And then, do we think that at the time in 2015, were there any other things that we should be thinking about? Anybody had any thought on that?
So I'm assuming she, in addition to standard loop diuretics, was on eplerenone or spironolactone.
She was on spironolactone 25.
Yeah. And 2015, I don't think ivabradine was approved yet in the United States, but given her baseline EKG, where her sinus rate was above 70, it's certainly something that could be considered now. Certainly,
it's a good point. And you're right. At that point, that wasn't a current option. It's relatively contraindicated in people with AFib. Now, she didn't have a lot of AFib at the time, but ivabradine is really only, felt to be useful in people that weren't having AFib. And then the other part is that it could exacerbate AFib. So anyway. So I will also point out that in 2014 she had some PFTs, which the highlights of that PFT report are here. So she has a sort of a mild to moderate restrictive defect, and her DLCO was 54% of predicted. So some evidence of, chronic lung disease, presumably from her episode of ARDS. We did do a cath, and oh boy, I don't know why that's not showing up either. Her cath was basically normal, so that's her left system there. Her right coronary artery was basically normal. Having some sort of artifact there, those bright spots are not real things. So in 2017, when she got admitted to the hospital with about 3 or 4 weeks of progressive shortness of breath, these are her EKGs at the time. So the one on top is when she first presented, and the one on the bottom is like about 12 hours later. She had, a change in rhythm while she was in the hospital. So I don't know if anybody wants to comment on these.
Atrial fibrillation.
Yeah, so the top one is, sinus rhythm. left bundle branch block, basically, or atypical left bundle branch block, with a QRS duration that was, it was certainly more than 120. It was probably more like 140 or 50 at this point. And then the bottom EKG, the left bundle pattern is obviously still present. And then she really, you can see, some identifiable P waves occasionally, but an irregular rhythm that suddenly changed. This was functionally, atrial fibrillation or flutter at the time. And this was also, her blood pressure was recorded in the 70s or 80s at this time. So, does anybody have any? Here's her chest X-ray on admission. So, what does everybody think about this, or does anybody have a comment?
Volume overloaded and heart failure.
Yeah, and you can see the dual chamber ICD, the atrial lead, the RV defibrillator lead. She does have some, prominent hilum, which is probably reflective of some pulmonary hypertension, and then a lot of stringiness in her pulmonary, in her lung fields. I don't know if that's only reflective of the pulmonary edema or if it's sort of indicative of prior lung injury. So I think that it's kind of hard to know about that.
Yeah, you have an EMT.
I'm sorry?
You have an EMT at this time?
Yeah, this was 1800. So looking back at her device, I thought I'd pick out some other things that are on the report. So does anybody want to comment about what they see here?
So you've had some recurrence of atrial tachycardia or atrial fibrillation in the course of July to December 2016. And not frequent episodes, but each episode does have multiple hours of duration, up to approximately 10 hours back in August, and multiple shorter episodes in December. The heart rate also, on average, is in the 80s to 100. That's her average heart rate.
Yeah, so as you're pointing out, these are marking episodes of atrial tachycardia or atrial fibrillation lasting for, 8 to 10 hours in this situation. And then right before she came into the hospital, you see she had, these little teeny lines. You can't see those, but they're little short episodes of atrial fibrillation. And then these are longer episodes, including right before admission there was, a 6-hour episode. And then looking at her heart rate, her maximum heart rate is always in the 110 range, it seems like, but then there's sort of gradual increase right before admission. So you can see her average heart rate or our maximal heart rate is getting quite a bit faster. And then right before admission, you see the mean or the minimal heart rate also jumps up. And then kind of interesting, if you look at her activity level, sort of going along okay, and then it starts to really drop off. So those are just some things that you see in these devices that, you can entertain yourself with some of the data that's in the 30 pages of report. And then this is the, sort of summary device interrogation. So who's talking? The woman who's commented on the device interrogation before? Who is that?
Good morning. My name is Patricia Guerrero. I'm a cardiac electrophysiologist in Orlando, Florida.
Perfect. Well, then you can surely comment on this device or this page too. So we appreciate your comments.
Sure. So again, you have essentially counters and a cumulative of atrial arrhythmia burden. And in the column that is in the middle of the page, essentially it gives you a assessment of what has happened from August 26th to August 31st. And then since the last reset is the column to the right. So like in the last interrogation, her actual amount of pacing percentage is small in both the A and the B, but B pacing is about 10%, which is what it was when you showed us the interrogation from 2015, not significantly higher. But if you look at her atrial arrhythmia episodes, she has, in total time in atrial fibrillation, the total counters going back to August of 2016, which was the other graph that you had just shown us, tells us that she has spent about 16.5 hours in atrial fibrillation. In the last 4 days, which is the August 26th to August 31st column, which is in the middle, it indicates she's not spent any time in atrial fibrillation or atrial tachycardia. And so then it breaks it down by the duration of each one of these atrial arrhythmic episodes by minutes to an hour to 24 hours. And so the majority of them have been in less than a minute, but you have 6 episodes that are up to an hour, and then 2 episodes that were much longer but less than 24 hours. And then your PVC counters are at the bottom, and she had 1 episode of non-sustained VT. So PVC burden was about 283 in the last 4 days, and 13,000 in a period in the last 6 months, so August 31st to December 27th.
Yeah. So certainly where the interrogation before was fairly quiet, this one is certainly a lot noisier, and definitely atrial fibrillation or atrial tachycardia is certainly a more common event at this point. I cannot believe these loops aren't working, but anyway, let me pull them up here. Okay. Come on. How I get it to loop. All right, so you got to be quick. This is echo, a few weeks ago.
Certainly looks worse than my axis do here.
Yeah, so what would you consider the EF to be at this point?
Oh, 15 maybe?
Yeah, certainly less than 20. And if you look up here, the RV function may not be quite as good as it was. And then if we look at the MR, sorry.
That certainly is worse as well.
I'm sorry about my little video issues here.
The valve leaks are due to dilation, yeah?
Well, certainly,
because of the,
yeah, I mean, if anatomically on the first image, you know, the valves structurally look okay.
Yeah.
But with worsening LV function, certainly the MR seems worse. There's a short axis
of worsening, yeah.
There's a short axis. And then to add a little more spice to the mix, so here's let me get this one. So this is her right there, the tricuspid valve is severely leaky, as you can see there. So
what were the estimated pulmonary pressures?
Estimated pulmonary pressures were about 60 on this echo. But Patricia, what would you say about the ICD lead and the tricuspid valve and all that?
Well, you know, you definitely have a lead that is coursing through the tricuspid valve. Interestingly, your echo from 2015 really showed very little tricuspid regurgitation. It is possible that the lead may be tethering the valve, but the lead actually looks very septally displaced, which is how you would want it to be. And my suspicion is that you probably have more tricuspid regurgitation at this time because of increased pulmonary hypertension as a reflection of her worsening EF, worsening mitral regurgitation, and probably elevated LVDP. So it would be interesting to see if, and here again, you know, resynchronization therapy in a patient such as this that has mitral regurgitation that's not associated with structural heart, you know, with structural valvular disease, you could improve mitral regurgitation with CRT, and then it would be interesting to see if, with improvement of pressures, that your tricuspid regurgitation would also improve.
Yes, well,
Patricia, what do you see in terms of the use of RCT in patients with non-ischemic cardiomyopathy? What kind of results do you see compared with ischemic?
Well, actually, you do see greater improvement in ejection fraction in patients with non-ischemic cardiomyopathies that have a left bundle pattern with a QRS duration that is longer, greater than 135, 140 milliseconds. They definitely have a greater likelihood of being responders to those patients with ischemic cardiomyopathy. And certainly if you have other patterns of intraventricular conduction delay. And we can be successful pending the location of the CS lead in improving mitral regurgitation. The problem with her is that you know, she has most likely chemotherapy-induced cardiomyopathy, and there's just not a large enough volume of of patients that have been selectively studied from this group of chemotherapy-induced cardiomyopathy in response to CRT. So we, I think we as electrophysiologists tend to just put them into the category of non-ischemics, meaning they don't have a scar. But unfortunately, there's probably a great deal of intramyocytic fibrosis, and so it's I think we would need to do some sort of long-term just surveillance of these patients with cardiomyopathy secondary to chemotherapy and see what their response would be to these therapies that we have customarily provided to other types of cardiomyopathy. In the non-ischemic world, most of them have been viral, to the best of our knowledge.
Yeah, so there is a study ongoing with that we're participating in, and maybe some others on the call, but called MADIT-CHIC, which is basically the MADIT group from Rochester, and the CHIC part, CHIC, is chemotherapy-induced cardiomyopathy. So patients that have systolic heart failure and they have a left bundle, they're, and are being treated with a biventricular device or being studied with, baseline echo and follow-up echo and clinical events, etc. So with and I know that there's probably been somewhere around 15 or so patients enrolled in that study. So I know that there will be at least some data specifically for this population, but I would also say that I have no reason to suspect that any cause of a non-ischemic cardiomyopathy that has a left bundle is probably going to benefit from biventricular pacing, regardless of the etiology. But certainly we will have a little bit of data in this population, hopefully soon.
Do you think you would help you differentiate in this situation who might not benefit?
I'm sorry, I couldn't quite understand that.
Do you think LV strain, longitudinal strain, or whatever you're using, would that be helpful in trying to distinguish which patient may or may not benefit from the CRT therapy? Impossible. It's possible, but the thing about strain is that it would be, it's mainly been looked at in people with normal function, and so in somebody with severe systolic dysfunction, especially with a left bundle, it's certainly going to disorder your strain value for sure. So I don't know how that would help you decide. I think clinically the decision about biventricular pacing is still the best tool that is helpful, is still the QRS duration. Unfortunately, I don't think there's anything better. Patricia, would you say differently, or?
Yeah, QRS duration as well as the morphology and having viable tissue.
Right. Well, and then the only other question that I put out here, because actually in this patient it's what I have recommended, but we haven't gotten to this yet, is I really would feel fairly strongly that you should put a epicardial lead in this patient because of the severity of the TR. But I don't know if Patricia would agree with that or not.
Well, the addition of an endovascular endovascular approach to the lead would not necessarily worsen your tricuspid regurgitation, because remember the auth of the CS is proximal to the valve, so we're not traversing the valve to put the CS lead in.
No, but the defibrillator lead.
Oh, the defibrillator lead. So you're contemplating removing the defibrillator lead?
Yeah, I would say that this would be a reason to do that. If you were, I mean, the severity of the TR is quite significant, and so you extract the ICD lead and place it epicardially. The coronary sinus lead would do it like the usual way, but
there's pretty good evidence that, especially in somebody like this, that the ICD lead traversing the tricuspid valve has led to, some, ultimately, destruction of the valve, at least in terms of functional status. And so I think that there is some suggestion that, it should place an epicardial lead in this instance, but I don't know if you would agree with that or not.
I wouldn't. I don't agree at this moment to do that. I think that to do a laser lead extraction of a lead that's been in for many years is not an insignificant risk in someone who is as ill as her. And if you look back at your echo from 2015, understanding they think that the ICD was implanted years prior to that, you really didn't have significant tricuspid regurgitation. So can you really claim with enough assurance that the magnitude of the tricuspid regurgitation is really a reflection of the lead distorting the valve function versus is it just a reflection of her worsening LV function and worsening LVDP that prompts pulmonary hypertension and subsequently tricuspid regurgitation. So I think before I would subject this woman to a bigger surgery than she needs to, I would first put in a CS lead, hope for some improvement in her LV function, and then reassess the magnitude of the tricuspid regurgitation. You can always go back and take the lead out if it doesn't improve. But epicardial defibrillation leads, and we did this long ago when the endovascular ICD leads were not available, and patches and things like that, were not necessarily had as good defibrillation thresholds, and they had technical failures. And in some measure, you have to have a lead to generate the CRT unless you are contemplating doing LV pacing only. So how would you deliver that additional pacing of the septum if you don't have a lead, any lead? So if you're removing the defibrillator lead, are you going to put a pacing lead in, or you're going to do only LV pacing? Yeah, before I would put her through a big surgery, I would try just upgrading her to CRT and reassess what happens with her functional status and her hemodynamics.
Yeah, so I mean that's certainly reasonable. I think that we've actually had a fair amount of experience, and I mean the EP people here do extractions all the time, so although there are certainly risks, they don't necessarily see that as a huge risk, and placing epicardial leads for pacing or whatever is something that we do. I wouldn't say we do it frequently, but so anyway, but I think your comments about placing an LV lead and then see what happens and then decide later if you need to do a bigger procedure is certainly reasonable. The other part is, when she was in the hospital and developed atrial fibrillation, she was on dofetilide and metoprolol prior to admission with her blood pressure in the 80s. We had to make a decision about what rhythm medication to use, if any, and we didn't talk about that so much, but I felt like the only effective drug would have been amiodarone. The problem there is that she has this history of ARDS and has some evidence of restrictive lung disease. So, certainly that's a relative contraindication to amiodarone. The problem is that you don't really have any other effective choice in this particular patient. And so I will close this one out by just talking about other things. Is this a patient, so she's 57, she's cured from her ALL, she does have some underlying lung disease of kind of a mild to moderate severity. And then, you know, the patient actually asked me if she was a candidate for a cardiac transplant. And I was like, oh my God, I don't want to think about all that. But so I don't know what the people on the call feel about the advanced therapy in this particular patient, if she can improve with, say, IV pacing.
I'd like to ask a brief question about the usefulness of the strain, the segmental analysis of the strain echo, if it could help in anything, if you see the segmental strain analysis.
You know, I think it's the problem with strain in this setting is a combination of, you know, atrial fibrillation, severe LV dysfunction, and a left bundle branch block, and somebody who has a pacemaker. You are so out of the range of normality for strain measurements that I don't know what to tell you about that. I don't think that there are too many things that are affecting your strain evaluation in this setting. Eric, I don't know if you have a different comment about that.
Yeah, Dan, we do strain on everybody just to keep in practice, and this has not been helpful to us. It's taken us 4 years of doing strain before we could find some good correlates and we could really use it for something. But this is not one of the cases, although we do strain on everybody just to practice.
So, you know, I think that the current plan in this patient is to, you know, ultimately make sure she stays in sinus rhythm if possible. And then the other piece is to do IV pacing, and, you know, that's the recommendation at this point. But if she doesn't get better, do we have to consider some other advanced therapy? And I think that I would have some hesitation about that just because of her possible lung disease, but I think that we would probably need to define that better. And I just wanted to point out that, you know, these issues are becoming more relevant to the advanced therapy world. This is a report of those patients on the UNOS list that you know, the transplant list that have a history of anthracycline-related treatment or chemotherapy-related treatment. And you can see that over the last decade, the incidence of people showing up on the transplant list and ultimately getting transplanted is rising significantly. And I think that that's sort of going along with the idea that patients are surviving longer from their cancer. And then the good news is that when you look at their chance of surviving after transplant is basically the same as from any other kind of cardiomyopathy over the next 10 years. So that's good news.
So Dan, our longest survivor, has been 33 years, and he's a gentleman who had osteosarcoma and had adriamycin course and basically had end-stage cardiac disease from adriamycin and was on a dobutamine drip and flown in by helicopter, and we transplanted him 33 years ago, and he's doing very, very well today, and it is a testimonial to the value of transplant in patients with adriamycin cardiac toxicity.
That's extraordinary. 33 years is crazy. And then the last thing I would say is, you know, we can talk about all those things, but Dr. Lenneman, Carrie Lenneman at University of Louisville, is doing a study called the Seneca trial for stem cell therapy in patients with anthracycline-related toxicity. So if you have any patients that might fit in that category, please, you can contact us or contact her directly. If you don't know how to do that, we can make sure that you guys get in communication. But in any case, that's all I got for today.
Let's see, and then we could talk about Entresto in this patient if you want to try the patient on Entresto, but a blood pressure has been borderline. I'm not sure if she's on an ACE or an ARB.
No, hadn't been able to be on one.
Okie dokie. Well, thank you so much. We would like a volunteer for next month and the subsequent month's conference. So does anybody want to volunteer for next month among our group here today? Can we have a volunteer? All those who want to who don't want to volunteer, step back.
Potentially, maybe. I would like to introduce myself first. I am probably the only oncologist here, but I had 10 years research in cardiac field. So my supervisor is Dr. Sawyer, and I have been working on the chemo drugs or stress-induced cardiac myopathy field, and also I'm interested in those new developed targeted chemo drugs. See what they are side effects in the heart. We have been doing some experiment on mice and have some data, but before I make that decision, I need to talk to my supervisor to ask him if I can, talk on this panel. And but it's very good experience for me to study here. Thank you very much.
Yeah, you're welcome. Yeah, so Eric, we need to find somebody. So we'll send some emails out, but we don't want people to be shy.
I was going to say, this is Ann Blaze from Medical Oncology, and I think I have to double check the next date. We've got an interesting couple of cases related to imaging that I have to get our imager to agree to participate, and I'm on service at the beginning of March, but let me double check the dates because we might be able to do it.
That would be great. We'd love to hear from you. All right. Thank you, guys.
That would be March the 9th for anybody. Anybody's interested in volunteering, March the 9th.
Okay, thank you.
Yeah, thank you, Ann. I hope to hear from you. Thank you, everybody, for your attendance. Arjun, Ann, Calvert, Josh, Janine, Marty, Maria, Nadine, Patricia, Sebastian, Susan Dent,